So in the first session, we learned about the approach to anemia by Dr. Maman, sir. Though nutritional anemias are very common, but the second one one of the common entity that comes in the clinic is hemolytic anemias. Sometimes it is easy to diagnose, it is obvious, sometimes it is very difficult, and sometimes it is misdiagnosed. So today we have with us Dr. Sameer Melinkeri for discussing the approach to hemolytic anemias and how to do management for that portion. Dr. Sameer Melinkeri is basically a head of hematology and bone marrow transplant department at Dinanath Mangeshkar unit. He has done his MD from BJ Medical Pune, and thereafter he had went to CMC Vellore, where he took his master's or super specialty in hematology. And thereafter he has joined, he is in the practice since more than 15 years probably. There are many more things to say about Dr. Sameer sir, but he has requested not to say anything extra other than only these things. So I just stop here for the intro and ask sir to carry ahead.
Thank you, Dr. Sanket, and thank you for inviting me. Normally, for the last 3 consecutive years when Vedanta had organized CMEs in Ahmedabad, I was lucky to be a part of it, and I really miss being there physically. So I'm just sharing my screen now. Am I audible?
Yes, sir.
Okay, I'm not able to share my screen.
Siddharth?
Okay. Fine.
Yeah. Okay.
I hope it is seen now.
Yes, sir. Yes, sir.
Okay.
Good evening, Sameer.
Hi. Good evening. One second. Okay, there we are. Okay, fine. So let's discuss in hemolytic anemia. We'll first discuss a little bit about the physiology and anatomy of the RBC, which is quintessential, and that forms the basis of understanding how the hemolytic anemias happen. Okay. Not related to hematology, but this is a river from one of my favorite cities, and guess which one it is? This is the Sabarmati, a picture of which I took from my hotel when I'd come for one of my previous CMEs. Okay. So the normal RBC lifespan, as we know, is about 120 days, and the red blood cell, as we know, is like a it's like a Parley Poppins. There's a dip in the center, and there's an elevation towards the sides, and this is the side view, and this is so the normal mature RBC is about 7 to 8 microns. The capillaries are about 3 microns, and the slits in the reticuloendothelial system are about 2 microns. Okay, and so as you can see, when you look at it sideways, it's about 2 microns here. So imagine when this RBC has to go through capillaries, it has to really squeeze itself inside, especially in the RE system. And many times this is what happens. So these are slits in the reticuloendothelial system, and an RBC has to pass through this. Okay, so it has to literally squeeze itself through it many a times. And unless the RBC wall is really deformable, it cannot pass through this. And over and above this, when this RBC is trying to negotiate itself and going through the slits in the RE system, there are these macrophages which are sitting right outside over here, waiting to see which RBC is not good enough. The moment it sees that the RBC is deformed, it's not good, it has some problem inside it, these macrophages immediately bite that red blood cell and make holes into it and then destroy that red blood cell. Okay, so these are the kind of tests which the spleen and other reticuloendothelial organs subject the red blood cells to. Now, the RBCs have no nucleus, as we know, and therefore they cannot divide. There are no ribosomes, and therefore it cannot produce proteins. It does not have mitochondria, so there is no oxidative phosphorylation of its own, so it cannot generate its own energy, and it is incapable of de novo purine or pyrimidine synthesis. Now, often unfortunately I cannot ask in a Zoom meeting, but I often ask this question to my audience. Why is it that, so this is, as we know, is the hemoglobin molecule, and it has, we know that it has these this is the heme molecule, which consists of protoporphyrin, and in the center there is the iron atom. Okay, why is it that nature has selected iron inside hemoglobin? I mean, why iron? Why not zinc? Why not mercury? Why not molybdenum? Why not copper? Why only iron? Okay, this is a common question which I ask people, and the answer to this question is that iron is the only molecule or atom which is capable of getting oxygenated without getting oxidated. Okay, what does that mean? So, as you know, when oxygen comes in contact with any of these metals, it will immediately form an oxidized form. It will immediately oxidize that metal. But iron is capable of forming a very under very specific situations. It is capable of forming a very loose bond with oxygen. Okay, so it does not get oxidated. It sort of carries that oxygen, it like holds the hand of that oxygen. And this is important because when the hemoglobin, when the blood is flowing through the tissues and capillaries, and it has to disperse that, it has to let that oxygen go off very rapidly. It doesn't have much time. Blood flows at a great velocity, so it doesn't have much time for the oxygen to get dissipated. And if it forms a tight bond, an oxidized bond, the oxygen is not going to go quickly into the tissues, and you will have tissue hypoxia. So it must get just oxygenated and not get oxidated. And what maintains the iron in the oxygenated form and without getting oxidated, that is related to certain the net charge that certain molecules around the heme pocket provide. Okay, so there is this distal histidine, which is very important. There are some nitrogen molecules here, and this particular structure is quite important to keep that to prevent oxidation of the iron. So the iron oxygen interaction, iron is maintained in the reduced state. The protein binding of iron maintains this redox state, and any alteration of the protein binding causes oxidation of iron, and that leads to cellular damage. Now, hemoglobin is composed of 2 alpha chains and 2 beta chains, and in normal adult you have hemoglobin A, which is about 90%, 98% of the hemoglobin. Fetal hemoglobin forms about 1%, and the hemoglobin A2, which is alpha 2 delta 2, forms about less than 3.5% of the total hemoglobin. Now the alpha chains are produced on chromosome 16, and there are 4 alpha chains, as we know, alpha chain producing genes, and each of them contribute to about 25% of the total alpha chains. And on chromosome 11, we have the beta chains and the gamma and the delta chains. And so this is only about 0.5%, the fetal hemoglobin, about 1.5% of each of these. That's delta, that's a hemoglobin A2, and the beta chains produce about 48% of the beta chains. Now, the red cell requirements. Why does the red cell require energy? It requires energy for maintenance of the electrolyte gradient between plasma and red cell cytoplasm by ATP-driven membrane pumps. It needs to maintain the hemoglobin's iron in its functional reduced at ferrous state, and therefore it needs some energy to do all this. It needs energy for protection of metabolic enzymes, hemoglobin, and membrane proteins from oxidative denaturation, and it requires energy to preserve the membrane phospholipid asymmetry. Okay, these are 2 important vital biochemical reactions which happen inside the red blood cell, which help to produce one, it helps to produce ATP, So this is the glycolytic pathway, as you know, starts from glucose, getting converted to glucose 6-phosphate, and then this chain of events which finally forms pyruvate, and pyruvate sometimes becomes lactate, and this produces about 2 ATP, which the red blood cell needs. Remember, there's no Krebs cycle happening over here. Okay, Krebs cycle needs mitochondria. Red blood cell doesn't have mitochondria, and therefore only glycolysis happens here. And as an offshoot of the glycolytic pathway, there is another pathway called the HMP shunt, which we've heard, which we know about. And HMP shunt is important because this starts with glucose 6-phosphate, and this is important because of production of NADPH. It's a very important molecule which keeps the glutathione in the reduced state, and glutathione is required to fend off the reactive oxygen species that are formed constantly, which are attacking red blood cells. So it needs to neutralize these reactive oxygen species, and for that you need the HMP shunt. So any perturbation of this shunt or of this shunt is going to lead to hemolysis. Coming to the red cell structure, so the red cell membrane structure, so the red cell membrane is basically composed of 2 important proteins. One is the spectrin. The spectrin, it runs parallelly to the wall like this all over, and it consists of 2 folds, 2 chains, I would say. One is the alpha spectrin and the beta spectrin, and they are sort of it forms a helix. They form a helix around each other and run throughout the surface of the membrane. And then there are vertical. So this is the horizontal, stability. It maintains the horizontal stability, and the vertical stability is maintained by anchor ring, which binds to spectrin, and then subsequently to various other membrane-bound proteins, such as the band 3, the band 4.2, 4.9, 4.1, etc. Various proteins are there which maintain the vertical structure by binding to the spectrin. Okay, and this is important for maintaining the deformability of the red blood. So coming to how we define hemolysis. So hemolysis is any situation resulting in accelerated destruction of red blood cells and hence reducing its lifespan. Anemia, remember, may or may not be present. There may be hemolysis, but there may not be anemia. So mechanisms of hemolysis is you can have defects in hemoglobin, defects in the red cell enzymes, defects in the red cell membrane, and external factors which can rupture the red cell. So when you talk about cause of hemolysis, this sort of chart must flow through your mind. Okay, you must know. I often sort of memorize this chart by heart so that it becomes easy whenever you think of hemolysis. Just go through all these causes. So you can have intracorpuscular defects, meaning defects within the red blood cell, or extracorpuscular defects, something which comes from outside and destroys it. And intracorpuscular defects could be congenital or acquired, and they could be red cell membrane defects, such as hereditary spherocytosis, elliptocytosis, pyropoikilocytosis, defects in the red cell enzymes, which are G6PD, pyruvate kinase, and some others, many others, which are rarer. Hemoglobin defects such as the thalassemias, or structural defects in the hemoglobin such as Sickle, hemoglobin E, D, and others. Then methemoglobin and unstable hemoglobins. These are all defects in the hemoglobin in the hemoglobin protein. And the only acquired intracorpuscular defect is PNH, which also we will discuss. Then comes the extracorpuscular causes. Okay, something from outside the red blood cell is coming and destroying the red blood cell. And here you can have either immune or non-immune causes. In immune, you have autoimmune hemolytic anemia, alloimmune hemolytic anemia, such as an mismatched blood transfusion, or in erythroblastosis fetalis. And in the non-immune causes, you have microangiopathic hemolytic anemias, which are HUS, TTP, and DIC. You have traumatic hemolytic anemia, such as the cardiac, dysfunctional cardiac valve, or March hemoglobinuria, in which after a strenuous march, the soldiers tend to have hemolysis when the blood is passing through their feet. Then infections such as malaria and babesiosis, and toxins, gas gangrene, snake venom, and copper. These are certain toxins which can cause hemolysis. Okay. And coming to the sites of hemolysis, you can have either extravascular hemolysis or intravascular hemolysis. And actually, more often than not, you will have a combination in many of these causes of hemolysis. You have a component of both of them, although one may predominate. So when you have intravascular hemolysis, let's see what happens. The red blood cell ruptures and there will be hemoglobinemia. The free hemoglobin enters the blood, right? And then there is methylalbuminemia, and then there is hemoglobinuria and hemosideриnuria. When hemoglobin is released from the red blood cell into the blood, it is immediately bound to haptoglobin. It's a protein called haptoglobin, and the hemoglobin haptoglobin complex is quickly cleared from the plasma by the hepatic reticular endothelial cells, because free hemoglobin is toxic. Okay, you can't have free hemoglobin floating in the blood, so it is immediately bound to haptoglobin and cleared off from the liver. And then the haptoglobin levels, if you check them in any they'll be markedly reduced to absent. After the haptoglobin is saturated, there's still free hemoglobin floating in the blood. It enters the kidney, and from the kidney, it is toxic to the kidneys, and therefore the kidney tries to quickly reabsorb it back again. And while it is getting reabsorbed in the proximal tubules, inside the epithelial cells of those tubules, the hemoglobin is broken down and the iron is recovered. Okay, that iron gets converted into ferritin and is stored inside the tubular epithelial cells. And when the tubular epithelial cells are sort of, they have a process of, denuding and then getting excreted through the urine. And when you look at the urine of these patients who have had hemoglobinuria, you will see that these cells which contain iron-stained hemosiderin inside these cells, and that is called hemosideриnuria. Okay, so hemosideриnuria is an indicator of recent hemoglobinuria. So hemoglobinuria typically happens when there is severe intravascular hemolysis overwhelming the absorptive capacity of the renal tubular cells. And this is what I just mentioned, that it's an indicator of hemoglobinuria. When you have extravascular hemolysis, which is actually 90% of the cases of hemolytic anemia, you have predominantly extravascular hemolysis, where the red blood cells are not destroyed inside the blood, but they are removed by the reticular endothelial cells. And there is an exaggerated removal of these reticular of these RBCs. Now, when in extravascular hemolysis, when the RBC is broken down, again iron is released, which gets bound to transferrin. The globin is released, which forms amino acid broken down to amino acids, and these are again reabsorbed. And then the protoporphyrin gets broken down, and you have bilirubin, unconjugated, and then which goes into the liver and forms conjugated bilirubin glucuronides, and that they get excreted in the urine and stools. Okay, this is what we already know. Just to mention that certain features of extravascular and intravascular hemolysis. So in intravascular hemolysis, often the peripheral smear may show schistocytes. In extravascular hemolysis, you often see spherocytes. The haptoglobin will be decreased to absent in intravascular hemolysis, whereas in extravascular hemolysis, it is only a mild decrease. The urine hemosiderin will always be positive in a significant intravascular hemolysis, negative in extravascular hemolysis. Urine hemoglobin could be positive in intravascular hemolysis. The DCT, the direct antiglobulin test, is usually negative in intravascular hemolysis and positive in certain cases where there's autoimmune hemolytic anemia. In extravascular hemolysis, it's the commonest cause of extravascular hemolysis, I would say, and therefore that is important to do whenever you suspect that condition. And LDH is increased in both. Whatever the cause of hemolysis, you will have a raised LDH. So as I said, most hemolytic anemias have an element of both extravascular and intravascular destruction. Okay, now we'll come to the causes of hemolytic anemia, and we'll discuss some of the common and important causes of hemolytic anemia. Okay, so you have a 30-year-old lady who is presented with chronic anemia since childhood. Moment you say since childhood, whenever you ask for history of anemia, you must ask for whether since when the patient has been having it. Has it been there in childhood or a recent onset? So in childhood, meaning you're looking at a congenital cause. The patient has intermittent jaundice, and on clinical examination, the spleen is 4 centimeters, and the ultrasound shows that there are gallstones which are asymptomatic. So when you see this particular case, you know there is a chronic hemolysis. When you have a splenomegaly, it means it's a chronic hemolysis, and this is since childhood. So when you look at the peripheral smear of this patient, you will see probably the slide isn't all that good. It's a little faded. But if you look at these cells, you know that the normal red blood cell is supposed to have a central halo, right? There's a central halo here, and then only the peripherally you'll see the hemoglobin. But here you can see in these RBCs that there is no clearing in the center. They're all fully hemoglobinized cells, and these are spherocytes, right? These are spherocytes. This is hereditary spherocytosis, which is one of the commonest causes of membrane disorders of RBCs. It has a very diverse clinical presentation, and most patients present with either severe hemolytic anemia or mild hemolytic anemia, not requiring any transfusions. The classic feature is that on the hemogram, you will have a high MCHC, right? Mean corpuscular hemoglobin concentration is very high. And why is that? That's because the red cells, because the membrane is defective. Whenever these RBCs are trying to come out from in the slits in the RE system, the macrophages keep on realizing that it's coming very slowly. It's not getting deformed properly. There's a problem in the membrane. So it tries to bite the membrane and break it off. And as it bites and breaks off the membrane, there is loss of membrane, and therefore the RBC tries to remodel itself by trying to stretch the remaining membrane to cover that part which is bitten off. And in this process, it becomes spherical in size, because when it keeps remolding, it becomes spherical in size, and tightly it binds the hemoglobin inside, whatever hemoglobin is there inside it. And therefore, the mean corpuscular hemoglobin concentration is very high. Patients will have jaundice, they'll have a splenomegaly, they may have gallstones. Chronic leg ulcers is another common feature of these anemias. And splenectomy is very effective in curing these patients, but you do the splenectomy only if a patient has significant anemia or recurrent gallstones or leg ulcers, in which case, once you do the splenectomy, these patients' hemoglobin will be normal. The diagnostic test is an osmotic fragility, which we can commonly perform, but a more sophisticated test when the osmotic fragility is a little, OF is a little, what shall I say, a little less sensitive or a little crudish test, and therefore the eosinophil maleimide test, which is available at KM Hospital in Mumbai, they routinely do it. That can diagnose it. Osmotic gradient ectocytometry not routinely available, and mutation analysis by gene sequencing to identify what mutation the patient has. This is a rare condition called elliptocytosis, not so rare in Southeast Asia. Commonest area is Southeast Asia, where you have a lot of patients of elliptocytosis, but most of the times these patients are asymptomatic and have a very mild anemia. And a very rare condition called pyropoikilocytosis, whenever the sort of RBCs are subjected to heat, they just rupture and form a very sort of bizarre shapes. These are very rare. I've seen only one case in my life. Okay, the next case. This is a 10-year-old boy who develops a viral infection, and subsequent to that, he becomes suddenly anemic, and he passes a cola-colored urine. His hemoglobin is 4 grams, the retic count is 15%, and the DCT is negative. Okay, the retic count, as you know, reticulocytes are precursors to the red blood cells, and any condition where there is peripheral hemolysis and the marrow is functioning normally, the reticulocytosis will be there. The retics will increase but that's a clear indicator of hemolytic anemia. So here the DCT that is negative, and the urine hemoglobin is positive. Okay, so this is this condition is a young boy who has developed rapid onset of hemoglobinuria, and the commonest condition for this, you would suspect an enzymopathy. Now, red cell enzymopathy can be associated with hemolytic anemia, and these could be of either the problems in the glutathione metabolism, as I discussed earlier, in the HMP shunt, or enzymes in the glycolytic pathway. Much more common is disorders of the HMP shunt and glutathione metabolism, and the commonest condition that we come across here is the G6PD, glucose 6-phosphate dehydrogenase deficiency. Now, G6PD didn't go into too much of details of this for you. You can just remember that I often remember it this way. Okay, now G6PD and sickle cell disease. These are two diseases which in the world's population are common in India, the Arab in the Arab countries, and in the blacks, in the African blacks, right? So sickle cell disease is much severe in blacks as compared to Indians and Arabs. Whereas exactly the opposite is in G6PD. The Indian and Arab G6PDs tend to be quite severe, but the blacks it tends to be quite mild. Okay, so you can sort of try and remember it that way. So there are various mutations which are commonly seen in the Indian and Arab types, which tend to lead to a particular type of G6PD variant called as the G6PD Mediterranean, which often tends to be very abnormal and quickly gets denatured and destroyed. Whereas there's a G6PD A and B, which is B is the routine, is the normal one, but G6PD A is a subtype which is seen in the commonly in the blacks, and that tends to be the mutations causing this G6PD are quite mild usually. So what's the pathophysiology? Now, as I said, RBCs are born with whatever material they get at birth. They have to live with that. Okay. So as the red cells age, the activity of the G6PD declines exponentially because it tends to get utilized, right? So when the aged RBCs will have lesser amount of G6PD within them. And the in vivo half-life of G6PD is about 62 days only. Normal old RBCs will have sufficient G6PD to generate NADPH and therefore sustain the GSH levels, that is the glutathione levels in the face of oxidant stress. But the G6PD variants are associated with hemolysis. They are unstable. They have a much shorter half-life. Okay, and therefore you will have when the G6PD level is less, you will not have formation of the NADPH, and therefore glutathione will not get reduced, and therefore the reactive oxygen species can come and damage the red blood cell. That's the mechanism. Okay, this is what I just discussed. And once the reactive oxygen species they come in and they enter the red blood cell, they can cause denaturation of the hemoglobin. And the denatured hemoglobin is seen as something called as Heinz bodies, which I will show you. And they can also denature and oxidize the membrane. Okay, and therefore the membrane will form polypeptide aggregates, causing rigidness in the membrane, non-deformable RBCs, which tend to undergo extravascular hemolysis. If you look at the peripheral smear of a patient who has had a G6PD and a recent severe hemolysis, you will see two characteristic features. One is called as the, I'm sorry, this is not a very bright slide, but this is called as you have bite cells and blister cells. Okay, this is a blister cell. So you can see over here, there's a cell over here, and there's like a blister over here. And then you have a cell like this, which is a bite cell. So as if something has bitten it off. Okay, and that's typically what happens because the macrophages remove the denatured hemoglobin. It is recognized by the macrophage, and the macrophage tries to gobble up the part of the hemoglobin which is denatured, and therefore it can form cells like these. Importantly, when you're trying to diagnose G6PD, never check the G6PD level during an acute hemolytic episode. Why? Because during acute hemolysis, you'll have a brisk reticulocytosis. And because of the reticulocytosis, reticulocytes are born with, they will have a higher content of G6PD. And therefore, the G6PD levels may become falsely normal. So when the reticulocytosis, sometimes it can go up to 30% reticulocytes, right, in a severe hemolysis. So when the reticulocytosis settles down after a period of a few weeks, that's the time when you must check the G6PD levels. And the treatment is only supportive. You give blood transfusion support, give good hydration, and avoid drugs and oxidants known to precipitate attacks in these patients. The next condition, which I'm going to talk about, is unstable hemoglobins. So these are rare disorders in which you have structural abnormalities in the globin. Okay, so if there is a mutation which leads to a defective defective globin chain, then there would be substitutions in the primary sequence would lead to alterations in the quaternary and tertiary and quaternary structure of the hemoglobin of the globin protein. And this leads to unstable globin polypeptide chain or a hemoglobin tetramer. And these precipitate inside the red blood cell. So these mutant hemoglobins with substitutions that alter the structure and solubility of the molecule, the unstable hemoglobin precipitates as intracellular inclusions or Heinz bodies inside the red blood cells. And these Heinz bodies, when they are sort of being passed through the, when they are subjected to the macrophages will will try and engulf these Heinz bodies and therefore damage these red blood cells and cause hemolysis. How do you diagnose these conditions? So in G6PD or any condition which has caused oxidant hemolysis to the red blood cells, that causes denaturation of the hemoglobin, you will see a lot of Heinz bodies in these cells. So this is a Heinz body preparation in which you look at the RBCs. Normal RBCs may have one or two Heinz bodies, but ones which are really bad, they will see you'll have multiple Heinz bodies seen like this, and this is classical of Heinz body hemolytic anemias. Where do you see Heinz body hemolytic anemias? In unstable hemoglobins, drugs and chemicals that can cause oxidant damage, and the congenital enzyme defects affecting the glutathione metabolism. Right. Then there could be other glycolytic pathway defects. These are all the enzymes that are there in the glycolysis pathway. Very rarely you can have defects in all of these. Commonest is pyruvate kinase. You have rarer than that is the pyrimidine 5 nucleotidase, and then some of the others as well. And these are rare. You'll have to, so either you have to diagnose these. You will have patients will present with hemolysis, and you have to do the red cell enzyme assays. Some of these red cell enzyme assays can be done in the Institute of Immunohematology at KEM Hospital in Mumbai. And otherwise, nowadays, whenever we suspect it, we do send a clinical exome sequencing with which you can identify the mutations which are known to cause some of these defects. Okay, then coming to the next set of causes of hemolytic anemia, and these are the hemoglobin variants. Okay, so numerous inherited abnormalities in the hemoglobin molecule or synthesis would make the RBCs prone to premature hemolysis. And predominantly, you have the sickle cell syndromes and the thalassemias. So, patient. I unfortunately don't have the time to discuss sickle and thalassemia because these are really big topics. They need a separate lecture to be covered, and therefore I'm not going to cover too much about this. We'll move on to the next cause of hemolysis. So this is a 40-year-old man who develops symptomatic anemia, and this is happening recurrently 3 months. There are no specific clinical findings. So this patient has no organomegaly, and if you look at his hemoglobin, he has only severe anemia with the MCV being normal and retics being high. So I'm sure Dr. Mamun would have discussed in the approach to anemia. You have discussed that when you see microcytic, the easiest way to classify anemias is based on the community dealing with iron deficiency or with lead poisoning. If you're looking at macrocytic anemias, you're probably dealing with megaloblastic anemias and certain other causes. And most of the hemolytic normocytic category. Okay, so you must suspect a hemolytic anemia when the MCV is usually normal, and the retics are of course high. The PBS is unremarkable, and the DCT is negative. So what could this patient be having? Recent onset hemolysis, so obviously it's not congenital. He's got pure anemia, so unlikely to have a problem inside the marrow right now, and there is hemolysis. The DCT is negative. So in such a patient where the DCT is negative and you're not able, on the PBS is completely unremarkable, you must think of PNH. Okay, PNH is an acquired cause of intracorpuscular defects. Okay, and it's a one of the marrow failure syndromes in which there's intravascular hemolysis. There is anemia, leukopenia, and thrombocytopenia, which can coexist because it can convert. You can have a partial conversion into aplastic anemia in PNH. You may have a hypocellular bone marrow, and there's an increased risk of thrombosis, which I'll explain why. So PNH is a very interesting disease. You have an acquired mutation in a gene called as the PIG-A gene. Okay, this is the PIG-A gene leads to a defective production of the phosphatidylinositol-glycan anchor protein, and this is a protein which sort of anchors several other proteins on the surface of the red blood of the blood cells. And out of these, two important ones called as the deaccelerating factor or the membrane inhibitor of reactive lysis, called as the CD55 and CD59. So because the GPI anchor is lacking again. As I said, this is the CD55-59 will be absent, and therefore complement complexes are not fended off and from the surface, and that makes the RBC prone to complement-mediated lysis. Okay, fine. Yeah, this is what I just sort of explained. And so PNH used to be previously diagnosed by the Ham's test and the sucrose lysis test, which are now obsolete tests. Nobody does these anymore. We now use flow cytometry to detect these missing proteins, the CD55 and 59 on the cell surface. And this is done by flow cytometry using the FLAIR technique. And you can sort of diagnose PNH very accurately. Even if it's present in minute amounts, you can diagnose it with flow cytometry. In PNH, this is a disease which the treatment of which is to prevent hemolysis. You need a complement inhibitor such as eculizumab, an extremely expensive drug. So most of the times we end up treating patients with the supportive care. We often use steroids during an acute hemolysis episode because to sort of shut down the inflammation in the body. And for long-term treatment, we often use a drug called danazol, which is an anti-estrogen, works like an anabolic steroids, and often helps in improving hemoglobin levels and reducing the amount of hemolysis, or maintaining not reducing the amount of hemolysis, but in maintaining the hemoglobin levels in patients with PNH. We find that drug quite effective. And the ultimate treatment is a bone marrow transplant, which is curative for this disease. Okay, next case. So the patient who presents to you with severe symptomatic anemia since 1 month. Okay, since 1 month, so obviously this is not congenital, acquired cause. There is normal hemoglobin. Normal WBC and platelets, and a very low hemoglobin. Now the MCV is 140. Okay, so extremely high MCV. Normal MCV is 80 to 100. So this is obviously very high MCV. So the first thing that you would think of when you see such a high MCV, you might think this is a megaloblastic anemia, right? But this is anything other than blastic anemia. Why? Because remember, in megaloblastic anemia, you will never have only isolated anemia. You will always have some degree of affection of the WBC and platelets also. You will have some leukopenia. You will have some thrombocytopenia. You cannot have only anemia. Okay, if you have only anemia with a very high MCV and a high retic count, you must think of this particular condition that we are going to talk about. And so you see, naturally, the hemoglobin is 3, so you want to transfuse blood quickly, right? So you ask the blood bank to urgently issue a unit of blood, and the blood bank calls back saying that we've been trying to cross match the blood, but we are not able to cross match any single unit. So what is this condition? This condition is autoimmune hemolytic anemia. It's a very important cause of hemolysis because it's probably the commonest cause of acquired hemolytic anemia. So autoimmune hemolytic anemia is seen typically with either IgM, so it's either IgG or IgM antibodies which act against your own red blood cells and destroy them. And these cells opsonize the red blood cells, and they are recognized as abnormal by the RE system, and therefore that leads to hemolysis. And you will see agglutination of RBCs in the peripheral blood like this. Okay, so the immunoglobulin molecules tend to form a lattice, and therefore RBCs tend to aggregate and form agglutinates like this. The PBS becomes classically this is a classical feature seen on the peripheral smear. And why does the MCV become so big? The MCV becomes so big because one agglutinate of RBCs, when it passes through the cell counter, okay, this is counted as one red cell by the cell counter, and therefore it gives a artificially spuriously high MCV. Actually, the cells are not all that big. Reticulocytes, remember, are larger than mature RBCs. As RBCs mature, they become smaller in size, and retics are always bigger in size, and therefore, because of the brisk reticulocytosis in hemolytic anemia, sometimes you may have a MCV which is on the higher side of normal. Okay, and you also see these microspherocytosis. So you have small red blood cells. Again, you don't have a central pallor. You have only fully hemoglobinized RBCs. These are again microspherocytosis. Again, classical of autoimmune hemolytic anemia. Again, because these antibody-coated red cells, when they're passing through the macrophages will keep on biting off parts of the cell membrane, where the antibodies are attached, and therefore, because of the remolding, you tend to have spherocytosis. And this is a nucleated red blood cell. This is not a WBC. This is a nucleated red blood cell, which is coming into the blood because of the rapid activity of the marrow. So AIHA can be of two types. One is the warm autoimmune hemolytic anemia and the cold. Warm AIHA is typically because of IgG mediated hemolysis. So it reacts at room temperature or warm temperatures. It is acute and severe, more common in the younger age group. And IgG, remember, does not fix complement all that avidly. Whenever a complement is fixed to the whenever the complement is activated, the red cells tend to get destroyed rapidly and often within the blood itself. Okay, so IgG doesn't cause much of complement activation, and therefore it is predominantly extravascular hemolysis. Retic is raised in about 50% cases only. Remember that. So in AIHA, you would expect that commonly reticulocytosis would be there, right? As in all other cases of peripheral hemolysis. But in AIHA, in at least half the patients, you will not have reticulocytosis. Why? Because the antibodies may not be against only the mature red blood cells, but they could often be against the reticulocytes as well. And therefore, if you have anti-retic antibodies, you will have lesser features of hemolysis. You may have just a mild features of hemolysis, just a little bit of you will have a low hemoglobin, but your LDH may not be all that high. Your indirect bilirubin may not be all that raised because the retics themselves are sort of getting destroyed. Okay. The spleen is the primary site of destruction. Spherocyte spleen in the peripheral blood smear, and they could be the primary in which there's no other secondary cause, or secondary to collagen vascular disorders or lymphoproliferative disorders, which commonly cause AIHA. And in warm antibody hemolytic anemia, the primary treatment is with immunosuppression, so steroids, primary line of treatment, and then other secondary drugs such as rituximab, some of the other immunosuppressants, and splenectomy are treatments for this condition. Now, the important question that you must that is asked is, in this patient where the hemoglobin is so low, is only 3 grams, and the blood bank is saying that there is no unit available for transfusion, will you transfuse that blood or not? That's the question. Okay, commonly asked. So you have to obviously transfuse. Now, why is this incompatibility there? So we'll discuss that in subsequent slides. So there's a 70-year-old man whom I had seen as a consult, who is premorbidly healthy. He underwent a bypass surgery after which he was in the cardiac ICU. Prior to the surgery, his hemoglobin was normal, and then after he was in the cardiac ICU in 3-4 days time, he developed gangrenous changes in both lower limbs, symmetrical up to the calves. Okay. When you looked at his CBC, the hemoglobin was low, the MCV was on the higher side, and the retic count was raised. So this condition is typically cold agglutinin disease. Okay, cold agglutinin disease is a condition in which you have RBCs which are destroyed by IgM antibodies, which fix complement, and this reacts only at cold temperatures. Okay, so when is the body temperature cold? Normally, it's always the same temperature. But when your skin is exposed to very cold temperatures, such as in very cold countries, or in this patient, he was sitting in the cardiac ICU with he was half naked, and his the AC was blowing onto him. Okay, and so therefore it was quite cold and chilly in there, and this patient had so when you're exposed to cold, when skin is exposed to cold, the temperature in the skin tends to decrease, and when the temperature decreases, these antibodies attach to the red blood cell, and then they cause agglutination of the red blood cells within the microcirculation, and when it's passing through the microcirculation of the skin, it tends to form aggregates, and therefore the circulation is very sluggish, and therefore you tend to have gangrenous changes in the or typically you have acrocyanosis, but in very extreme cases like in this patient, you can have gangrenous changes in the skin, right? So this is typically this is an autoimmune hemolytic anemia, which is which tends to be very mild, and most of the times all you need is to keep the patient warm. You keep the patient warm, the IgM antibodies will not attach to the red cells at all, and therefore there'll be no hemolysis. So all you need to do is keep them warm, and if they continue to have hemolysis, then you can treat them with certain immunosuppressant drugs. Otherwise, most of the times you don't need it, and immunosuppressants don't often work very well. Commonly seen in post-infectious conditions such as infectious mononucleosis or mycoplasma pneumoniae and lymphomas. Right. Okay. Now, coming to what is Coombs test, something which you must know. Coombs test is critical in evaluation of autoimmune hemolytic anemia. So what you do is you prepare an antiglobulin reagent. This reagent is prepared by injecting human globulin into animals. Okay, so typically you inject it into sheep, and then the animal will produce human globulin. So they'll produce antibodies against the human globulin, right? And these are then taken as the antiglobulin reagent, and you have IgG and you have C3. Okay, so C3 is a surrogate marker of IgM. You cannot have IgM in the reagent for certain reasons, and so you tend to have you have C3d as a component of the antiglobulin reagent. And when you so in a patient who has autoimmune hemolytic anemia, if you take his RBCs, they will always be attached to red. There will be IgG or IgM, which is attached to the red cell surface, and that's what you want to document. You want to document that the red cells are being hemolyzed by antibodies which are coating them, right? So how do you do it? So you take these patients' antibody-coated red blood cells and add the antiglobulin reagent to it. In the antiglobulin reagent, you have antibodies prepared in the sheep against human immunoglobulins, and therefore they will attach to the Igs that is bound to the patient's RBCs and form a lattice. And therefore, you'll see agglutinates, RBC agglutinates, when you add the antiglobulin reagent to it. You look at under the microscope, you'll see that there is agglutinates being formed. So this is the direct Coombs test, which tells you that there are antibodies attached to the patient's red blood cells. Now, when this is the DCT, I just described the mechanism. What is the indirect Coombs test? So when you have RBCs, when you have antibodies which have coated all the RBCs, and there is still a lot of excessive antibodies present, those antibodies are going to float in the patient's serum, right? So if you take the patient's serum and you take normal red blood cells from healthy donors, and you mix them together, these antibodies in the patient's plasma are going to bind to those red blood cells, right? And then you add the antiglobulin reagent and look under the microscope, and you'll see that there is agglutination. So this is called indirect Coombs test, in which detects presence of antibodies in the patient's plasma. Okay, so that is about autoimmune hemolytic anemia. Before coming on to the next case, let me just sort of mention to you that that these antibodies. Remember that in autoimmune hemolytic anemia, you will always have antibodies against only the minor blood group antigens of the patient. You will never have antibodies against the A, B, O groups. Okay, so it will only be against RH or MNS or I or one of the minor blood group antigens, and therefore these antibodies, if you need to transfuse these patients, you can very well transfuse them. You will never have intravascular hemolysis. Okay, so whatever incompatibility that you are seeing in the blood bank is only in vitro. It is not actually in vivo. If you transfuse this blood to the patient, those RBCs are not going to cause intravascular hemolysis. They're not going to lyse in the patient's blood. They are only going to be opsonized by these antibodies, and they will be removed extravascularly. So therefore, in an acute event, you can transfuse these patients with the so-called incompatible blood. It will stay in the patient's circulation for 1 or 2 days to tide over the crisis, and during that period you can so you start your steroids, and once the hemoglobin starts improving, you stop the blood transfusion. Okay. So coming to the next case, this is a patient who presents with altered sensorium. He has a hemoglobin of 9 grams, a WBC count of 8,000, and a platelet count of 10,000. Okay, so when you think of a patient who comes with altered sensorium and has a very low platelet count, the first thing you think of is that the patient could be having an intracranial bleed, and therefore you do the patient's CT, and the CT turns out to be normal. Okay, you look at his biochemical parameters; they are all normal. The retic count is 8%. Okay, so there is thrombocytopenia, and there is anemia, and there is a raised retic count. You do a PTA, APDT; these are also normal. LDH is raised, and the PBS shows schistocytes, right, and NRBCs. What is this condition? This condition is TTP, thrombotic thrombocytopenic purpura, something which you can never miss. Okay, why you should never miss is these patients are commonly thought to have ITP. Just look at the somebody who has a normal WBC count, slightly low hemoglobin, and a severe thrombocytopenia, you tend to call it as ITP. If you do a marrow in these patients, the marrow is going to be normal. So you tend to diagnose these as ITP. And then you would sort of just keep giving steroids. You might get worried about bleeding, and therefore you might transfuse these patients with platelets. The moment you transfuse these patients with platelets, they will land up with a stroke. Okay, why? We'll discuss. So, RBC fragmentation is seen in what we call as microangiopathic hemolytic anemias. You will, in the peripheral smear, if you look, you'll have schistocytes and microspherocytes. The common causes for these are HUS and TTP. In TTP, you basically have antibodies against an enzyme called as the ADAMTS13. I don't have the time to discuss this in too much in detail, but as you know, when ADAMTS13 is required to to cut the von Willebrand factors in the peripheral blood. And when if the ADAMTS13 enzyme is absent, then you will have long multimers of this of von Willebrand factor in the blood, and therefore von Willebrand factor, which is normally sort of whenever there is an injury to the blood vessel wall, the VWF actually layers out over there, and then the platelets sort of come and attach to the von Willebrand factor, and that's how you tend to have that you have a platelet plug formation. So if you have long aggregates of high molecular weight multimers of von Willebrand factor, it spontaneously tends to aggregate platelets within the circulation, and these platelet aggregates will get lodged inside small capillaries, and therefore you will have consumption of platelets and therefore thrombocytopenia. And when the RBCs are passing through these aggregates of thrombi, you will have schistocytes. You'll have fragmentation of these RBCs, and therefore you'll have schistocytes in the peripheral blood. Okay, now in this condition, why does this condition commonly develop? Most often because of antibodies against ADAMTS13. Okay, so it's an autoimmune disease in which you have antibodies against ADAMTS13. You diagnose this condition when you have a patient who comes with thrombocytopenia, severe thrombocytopenia, milder anemia, and schistocytes in the peripheral blood. If you do an ADAMTS13 level, it will be severely decreased. And the treatment of this condition is never transfuse platelets, because otherwise you're going to add fuel to the fire. The treatment is plasma exchange and immunosuppressants. The other condition in which you will see schistocytes is hemolytic uremic syndrome. Again, I won't discuss it. And in DIC as well, you have aggregates of thrombi in the peripheral, in the microcirculation, and therefore you have schistocytes. If you have a malfunctioning cardiac valve, typically the metallic valve, then when the RBCs are passing through that valve, they're going to get damaged and ruptured, and then you have constantly intravascular hemolysis. Okay, I just discussed all of this. Okay. So TTP, again, microangiopathic hemolytic anemia, thrombocytopenia, altered mental status, renal failure, and fever. The pentad of TTP. Treatment is plasma exchange. These are schistocytes, right? Now, it is very, very important for a pathologist to report that the patient has schistocytes. It's very important to recognize this condition and think of it and ask your pathologist, what are you seeing in the peripheral blood? Sometimes, so if you look at this PBS, there are also, some microcytes, some macrocytes, some this anisopoikilocytosis, you will have some pencil cell here and there. So all of these things, if they are mentioned by the pathologist, so you can have a cello here which looks like a pencil. So all of these things, if they're mentioned by the pathologist, then the clinician often tends to get confused. Okay, he doesn't look at it. So the pathologist in this, after looking at this smear, is supposed to call up the clinician and tell them, look, I'm seeing multiple schistocytes in the patient's blood. Okay, so this PBS is characterized by a lot of schistocytes, and then that should draw your attention. You must look. You must then think of a microangiopathic hemolytic anemia. There are some extrinsic causes of hemolysis, such as infections, clostridial sepsis, parasites such as malaria, common cause of hemolysis. March hemoglobin, I just discussed this, and copper toxicity seen in either copper sulfate poisoning or in Wilson's disease, and these also cause hemolytic anemia. So we've discussed most of the sort of important causes of hemolytic anemia, and finally, to summarize, let's see how to approach a patient with a hemolysis. So to prove that the patient has hemolysis, somebody comes with anemia, you want to know whether the patient has hemolysis. There are three important features. One, you will see indirect hypobilirubinemia, you will see a raised reticulocyte count, and you will see raised LDH. These things, three things will tell you that the patient has hemolysis. Then you want to know whether it is congenital or not. There's recurrent episodes of jaundice since childhood or anemia since childhood. And if you look at the patient, if the patient has these hemolytic facies, then these are features of a congenital cause of anemia. In your laboratory evaluation, initially you will do a CBC with MCV. I told you the importance of MCV. You will review the peripheral blood smear because sometimes there are glaring features on the PBS which will tell you what the cause of hemolysis is. You look at the reticulocyte count, you look at the LDH, bilirubin, direct and indirect, and consider haptoglobulin levels whenever you think there is a hemoglobinuria, and a urine analysis. If you see a low MCV, you think of a hemoglobinopathy. If you see a high MCHC more than 35, you think of hereditary spherocytosis. If the PBS shows things like spherocytosis or elliptocytes, sickle cells, target cells, bite or blister cells, schistocytes, these will directly indicate that particular disease. Okay, so this can give you a very good clue. Then you look at, whenever you suspect, you do specific tests such as osmotic fragility if you suspect hereditary spherocytosis, enzyme assays whenever you suspect an enzymopathy, and hemoglobin electrophoresis when you suspect a hemoglobinopathy. The second question you must ask is there hemoglobinuria? Is there any history of hemoglobinuria? If that is the case, then you're probably dealing with either these are causes of hemoglobinuria: an ABO mismatch transfusion, G6PD deficiency, PNH, black water fevers, malaria, and gas gangrene. These are common. These are causes of hemoglobinuria. So rarer causes, but if hemoglobinuria, cola-colored urine is there, then your differential diagnosis tends to be limited to some of these conditions. Okay, patient who comes with acquired hemolytic anemia. So it's a recent onset of hemolysis. You must ask the patient. You must ask yourself: is there associated thrombocytopenia? Okay, if there associated thrombocytopenia, then you're probably dealing with a microangiopathic hemolytic anemia. What does the peripheral smear show? Okay, that again, as I told you, will give you a direct cause of hemolysis. Look at the DCT. All causes of acquired hemolytic anemia, the first test that you do is a DCT because it's the commonest, AIHA is the commonest cause of acquired hemolytic anemia. And therefore, if the DCT is strongly positive, you're dealing with autoimmune hemolytic anemia. Ivan syndrome is a condition in which you have antibodies against both red blood cells and platelets. So, okay, so combination of AIHA and ITP, and that's called Ivan syndrome. Schistocytes can indicate microangiopathic hemolysis, and finally, if you don't see any of these features, okay, it's a recent onset hemolysis, it's an adult, the PBS is not showing any characteristic features, but there is a reticulocytosis, and the DCT is also negative, then you start thinking of PNH, and then you do the flare test for CD50.59 and you diagnose PNH. So this is a sort of broad and a simple approach to acquired hemolytic anemia. So to conclude, with a good, correct approach, most of the causes can be easily diagnosed. You must recognize autoimmune hemolytic anemia, PNH, and the MAHAs as early as possible because these are life-threatening illnesses. Okay, you must transfuse blood only if required, and blood can be transfused safely in most of these cases. So with that, I end my talk. I had limited time, otherwise hemolytic anemia itself can be a very large topic. So thank you for a patient listening, and I'll be happy to take questions.